Welcome to the EAU podcast. In this special episode, recorded live at EAU26 in London, we present Challenge the UROmigos. In this interactive live podcast session, Professor Brian Rini and Professor Thomas Powles brought their well-known UROmigos format to the Congress stage. Together with experts from the audience, they discussed evolving treatment strategies in genitourinary oncology, exploring current debates in bladder and kidney cancer, and reflecting on emerging evidence and its implications for clinical decision-making.
Welcome to this live podcasting session. Tom and I were asked to do this a while ago. We're thrilled to be here. So as I think many of you know, we've been doing this podcast actually for over 6 years. We're almost to our 500th podcast. And we're really thankful to be here. And so on a normal podcast, we have one guest with us virtually, and we're sort of going back and forth with that guest, as you may know. This is a little bit different. So the idea of this, we have a couple topics in mind, but we really want to hear from all of you in terms of what you want. We're going to start with the bladder topic. We have also a kidney topic. Come up to the microphones. You may be in danger of being pulled on stage, just fair warning. To introduce, my name is Brian Rini. I'm a GU medical oncologist from Nashville.
And I'm Tom Powles. I'm an oncologist too. Fabulous. So thanks for coming, so many of you. It's a big crowd.
The room is full if you can't see, if you're just listening.
If you're just listening, the room's absolutely full, isn't it, Brian?
There's people outside who can't get in.
But genuinely, if you do want to take part, we're super keen. Like really. Like anything, you can say almost anything you like. We're quite open-minded about the wording, aren't we? We don't mind greyish swear.
Yeah, no swear words, but that
ideally,
fine.
But okay. Where would you like to start?
All right, let's start. So we're going to start with the bladder topic. So Tom, I'm going to give you a scenario. So I am a 56-year-old medical oncologist. I have
Are you really?
I am. I have T2 bladder cancer. I was diagnosed, I have CT scan staging, okay, so I have no distant disease.
I don't think CT staging is that helpful.
Okay, hold on, just wait. Okay. I had a tumor-informed ctDNA that was negative. I have a urinary tumor DNA that
But you don't know that yet, because it takes 6 weeks to get a result.
Let's pretend I know it.
But this almost, so you've done, that's quite hard, because it takes 6 weeks to get that result.
Not in my shop. It takes 6 hours.
Okay.
We're very, very advanced.
Okay, but that's the reality, is that we all say we're going to have CTA analysis done, but we're going to have to make it turn around quickly if we're going to make decisions off the baseline level.
Fair enough.
I think what's going to happen is retrospectively we're going to find out that they were positive, and then you'll say, okay, what are we going to do?
Okay, so let's say you don't know my status up front for CT and UT DNA.
Okay, I'm pleased we've organised that.
Yeah, I'm glad we talked about this beforehand.
Yes.
So I have T2 bladder cancer. Yep. I go to you give me 4 cycles of EVP. I tolerate it pretty well. I've maybe got a little neuropathy, but I generally get through. I don't have any major toxicity concerns.
Yes. On 4 cycles of EVP.
You gave me 4 cycles.
Yes.
I come back to you. You're a urologist in this scenario. I come back to you and I say, hey, doc, talk me in or out of getting a cystectomy. Now I know my ctDNA. Let's say it was negative at baseline. It remains negative. And my urine tumor DNA is negative at this point, after 4 cycles of EVP. Talk me in or out of getting a cystectomy.
I mean, look, you've got a really kind of serious cancer. You've got historically, there's a 50% chance of this coming back within 2 years, historical data. And you've started a new journey with a neoadjuvant regime that's super active. The likelihood is, in the future, you won't be needing to have this operation.
Okay, but how about now? I got to make a decision right now.
This is what, if you want that 80% event-free survival at 2 years, this is what we did. We did the operation now, and then we gave you 4 or 5 more cycles afterwards, and then we gave you a year of pembrolizumab. And I don't think we need to deviate from that. That's what I'd like to happen today. Now, if you said to me, is there a trial where you could not have it? If you said to me, I'm not going to have it. I can have that discussion, but I'm not going to enter into this thing saying we just spent 30 years trying to develop an effective regime. We've done it, and now we're going to completely off piece and do something completely different.
So I have to have a cystectomy.
If you don't have a cystectomy and the cancer comes back and it all goes wrong,
I understand. But I don't want a cystectomy. Let's say I don't. Now I'm going to refuse. I don't want a cystectomy. What are my options?
I understand that.
I absolutely refuse. I was
speaking to a urologist on the way here. I don't know if they're here in the audience, who's done 7 cystectomies on neoadjuvant EV pembro patients, and 6 of the 7 have had a path CR, no cancer. And now he's saying, I'm not super comfortable just doing this for another 10 years of everyone not having cancer. So we're going to have to answer this question.
Okay.
We're going to have to answer this question. And in fact, there are trials answering this question. So we're going to do studies, and there'll be quite a lot of them. They'll be investigator-initiated. They'll be company-sponsored. There'll be EV Pembro, 9 cycles with surgery in the middle.
Tom, we have a real expert who's come to the mic.
That's very
Michiel
sweet.
van der Heijden. Yes.
Yeah, hi, Michiel van der Heijden. I'm a medical oncologist as well from Amsterdam. First of all, big fan of the show. It's great. And
we didn't pay him to say that.
So paying is over. I got paid. Can I get some money for this already?
Yes, of course.
We might buy you a beer.
So now I can.
It's a strong
Depends what you say a little bit.
Listen, of course, you're going to say that you want to do trials, and you feel obliged to say like, yes, you have to have the full regimen, a full year, and the surgery, and everything.
The whole shooting match.
I mean, look at Brian. Brian is a pretty smart guy. Looks pretty smart. He's a medical oncologist. He knows like, I'm going to have, for the whole group already a 60% chance of a bad CR. Now I have a T2 on a scan. Okay, you don't believe in scan? Fine.
I don't believe the scan.
I give negative urinary tumor DNA. The chance that I have a bad CR is really, really high. Can we do better than this? I mean, let's think a bit.
So, Michiel, so the answer of the problem I've got with this is, and Ashish said it in the session earlier, is the immediate temptation is to go off-piste. That's the immediate temptation because we know best. And how many times have we done trials when we ask a question which we think we definitely know the answer to, and we turn out it doesn't work out that way? How many times have we done that? It happens to me all the time. And my concern around jumping into we just don't need the cystectomy anymore at this point is that that's what we did. And we don't do that. We don't know that, I suspect you're going to be right. And I'm not just trying to tout that we should do the studies, but we should do studies, both single arm. I'd love to see there's going to be a big single arm trial of 500 patients or somewhere around there where you just get EV Pembro. You don't have surgery. You maybe have surgery in the middle. And then you'll be able to know. Because what's going to happen is I think these cancers,
Tom,
I think they're going to
nobody's arguing against doing trials, right? Nobody's arguing that, we shouldn't do the trials.
So then until we have that, let's do what we did on the
everybody has to undergo cystectomy.
No, because you're right. No, because this surgeon I met earlier on, nice man, and you were both saying to me, Tom, the pressure is not to do that. There's almost a danger in us not being able to do the trials, right? Because everyone's made their minds up, and there's no way that people are going to opt to have anything but that. And the whole thing's going to become, we're not going to be able to randomize and we'll have single arm data. What are we going to make of that? And that just worries me a bit, that we end up into Peter Albers in the room. Peter, you and I go back a long way. You will know in the past, we've done surgical trials where we thought we knew the answers to the questions beforehand, and therefore we were never really able to do the studies, and it just ends up getting adopted. And then we go back in time and said, did we answer the questions robustly?
I love how this topic worked you up so much. That's my favorite part.
Because you're so happy to go off-piste.
Listen, I'm all for the trials. I'm not arguing against it. But if I'm sitting in your office on Monday, right?
Yeah.
And I'm refusing cystectomy, what are you doing with me? What do you?
I'm giving you the full 9 cycles of every day of the week. Every day of the week. Michiel, you would agree with that?
So, I was hoping to steer you already a bit off track earlier, but okay, let's put it then a bit differently, because the reality is in the trial, they did a good job keeping everybody on track and getting surgery and actually getting half of the patients still adjuvant therapy. But in reality, a lot of patients are going to say, you can talk to me whatever you want. I'm not going to have this cystectomy. So what do you advise them in that situation?
So I would have 9 cycles of EV Pembro. I would not have radiation therapy.
Why not?
Well, what are you going to irradiate? This whole radiation thing, I'm a bit confused by. The bladder's there, there's no cancer apparently, and you can't see it on the MRI scan. Are you just going to, people say, well, go for the bed that was there before. But this just feels like in the 21st century, the sort of the era of AI and all that, we're just going to give radiation to the bladder generally and hope for the best. And there's no evidence that that's going. And of course, that worries me a bit, Brian, because that's worse.
I can tell.
But in the argument, what I'm.
But do you agree with me on the radiotherapy? Do you agree with me on the radiotherapy?
So what I'm a bit puzzled by, you are giving a cystectomy and another 9 months of
not 9 months
intensive therapy, and then
no. 9 cycles in all. You've already had 4. So that's 5 more cycles. It's a year of immune therapy. The majority of immune-related side effects happen the first 3 or 4 cycles. The majority of the adjuvant period of immune therapy is not associated with devastating toxicity. It's quite a low incidence of that. We showed that in Niagara. And that 5 cycles, that further cycles of EV compared to having a cystectomy, I think is a small price to pay. I think that's an attractive option. I am not happy around discussion saying, you know what, we've done all these experiments, we can just give 3 cycles and stop. That doesn't feel right to me. And we don't know enough about MRD. I accept the ctDNA data is really strong in this space, but we don't know how long you need to keep, how long EV pembro you need to give. ctDNA dynamics are different according to different drugs. Sure. And the ctDNA dynamics with EV pembro, we've got no idea at the moment.
Right.
So I'm not comfortable with that conversation.
I'm just saying we're going to be making clinical decisions in the absence of data for a while, right? Till these other trials read out or till we get data from 303 or 304, et cetera. We did a nice podcast with Mikhail on CT and UTDNA and remind me of the data. I think patients who were double negative, this is from Niagara, their past CR rate was 75%.
Yeah, and
something
in
like
that range. So only for urinary tumor DNA negative, the path CR was 72%. And then if you combine the two, there's a few patients that have the ctDNA positive and urinary tumor DNA negative. So it's probably slightly higher in the double negative group. It gets very technical.
Pretty darn high. Yeah. It's not 100%.
So
not
just,
100%.
But Tom, I don't disagree with you actually that you know, for now, for patients who, you know, are going to take the advice and have the cystectomy, but in the argument is a bit peculiar that you say I'm going to give a cystectomy and another, you know, whole set of therapy, but I think radiation is too much.
It's not too much. I just don't think it's effective. I think once you go off piste like this, I just don't think there's any data to support radiation in this space. Once you've made the decision you're going off piste, then I think doing more off piste stuff doesn't really help. I don't think there's any evidence that radiation in a path CR after EV pembro is helpful, particularly if you don't know what you're targeting. And so once you've gone off piste, it's like, okay, we won't do this, but we'll do something else bizarre. I don't think that solves the problem, you know.
Do we have any radiation oncologists in the room?
But we do have Shilpa Gupta.
Yeah. Can I ask a question?
Sure.
Shilpa Gupta from Cleveland Clinic, also a big fan of your show. So, Tom, you said that if somebody has a clinical complete response, why do radiation?
Yeah.
But you are pushing for radical cystectomy.
Because
they have a complete clinical response. But we have to use the data, like Brian said, we extrapolate data. Now, we don't envision doing an IMvigor011 trial for every regimen out there. It will take 5 years and the field would have moved on. So why can't we extrapolate something that Gemcis durvalumab, atezolizumab showed, or we've seen from Gemcis durvalumab to EV pembro?
So my concern around IMvigor011 is that I think it has quite big implications for those cancers where we have inadequate biomarkers. I think in kidney cancer, by the time you have radiological disease, you've got a big problem on your hands. If you have advanced bladder cancer, is a hard disease to treat. ctDNA allows us to treat the cancer earlier. A bit like PSA, by the time you've got measurable disease, soft tissue disease with prostate cancer, it's a real problem. Luckily, we've had PSA for a long time, and we are happy incorporating that into our pathway. We will do the same with ctDNA. The problem with IMvigor011 is it tells us when to start immune therapy. But the problem is adjuvant immune therapy is not the future. We're doing perioperative immune therapy.
But why can't we apply the data from the Niagara ctDNA data to EV pembro? Because,
well, 2 reasons. Dynamic changes with EV pembro are different from dynamic changes with platinum chemotherapy and immune checkpoint inhibition. We know the interaction between those 2 combinations are different. One appears additive, one appears antagonistic. So I'm not bought into that, number one. And number 2 is the ctDNA data from Niagara tells us 2 things. Number 1 is the most important thing is those patients that remain positive are in harm's way. And actually, if you're negative, you do super well. So why would you want to change a regime you're doing super well on? Why would you want to stop the immune therapy early if it's working? So my take on this is let's definitely give the year of immune therapy, irrespective of the ctDNA analysis. And those patients who we're not clearing ctDNA, let's switch therapy around. Petros Grivas wants to do studies in that population. I think it's going to be hard to do because the numbers are relatively modest. But in the end, that's our focus with ctDNA. Being positive is bad.
But Tom, what do you predict EV-Pembro would beat Gemcis, right? In the metastatic setting it has. So even if the dynamics are different, what would we anticipate in terms of ctDNA?
So the ctDNA analysis with EV-Pembro is going to show, so the first thing, and Mikhail, we had this, Jim.
It changed.
Mikhail, we had this discussion earlier on. You did your neoadjuvant Ipi-Nivo prior to radiation and Ipi-Nivo prior to surgery trials. And I was saying to you that I thought ctDNA at baseline is by far the most useful indication of your risk group, not T-stage. I think T-stage at baseline and grade or our baseline prognostication's really poor. And in one of the trials, in 905, the central radiology review showed 70% of patients had T3. And in the local review, it was only 30% had T3 disease. And so our T-staging is rubbish. Pathology is not helping us very much. And actually, 65% of patients in Niagara were ctDNA positive. And it was 30% of patients in your radiation study. And your curves, I think, look really beautiful. But I'm just telling you, it's a lower risk population.
So I think it was 35 and 55% positive ctDNA at baseline. So
Tom just makes up numbers.
Yeah,
it's fine. It's
okay. What was the point again?
Your population is at lower risk. ctDNA at baseline positivity, even if known in retrospect, is really helpful because you know the risk when you started.
Right.
So when I was saying you don't know when you start, that doesn't mean don't do it, because you do it and you're positive and then you know, God, I've got a problem in my hand. If you're positive at baseline, definitely give the 9 cycles. I agree, by the way, if you're CTA negative at baseline, you're UTDNA negative at baseline, and they probably got low, maybe you are a surgical patient under those circumstances.
But you're still recommending surgery for those patients?
I don't know the answer to that question.
Don't know the answer. Mikhail, what would you do in the scenario that I gave?
So I think at this point, I wouldn't disagree that this is the full package. This is what we tested, and this is what we should offer and advise. Only the reality is that a lot of people, especially the people who read these studies and they look at their chances and they know that their chance of a bad CR is super, super high. So we cannot ignore their wish to not have a cystectomy, because I can fully understand their wish. And that's difficult because then we have to work outside of what we've tested in the trial. But I think if patients who are persistent in that wish, we have to come up with something. And everything points in this case, to a patient who has either a path CR, very, very high chance, or limited local disease. In such a patient who really refuses the cystectomy, then I would say then radiation or chemoradiotherapy would be a good option, because we do see that patients who are on a wait and see, they do get local recurrences and they might sometimes get out of hand.
In the clinical CR patients, you're giving radiation therapy?
Currently, when we cannot accurately predict the local.
And are you giving the full 9 cycles in the full year of EV-Pembro? Someone's
adjuvant, well, that's then off label, so then you cannot give adjuvant anymore, I think.
So you would be stopping at that point, but that feels awful. That sounds like a really bad outcome to me.
You think so?
Well, why didn't we do the randomized trials with 4 cycles and radiation?
Well, if the label would allow me to continue, then
you would,
I could,
but
the label doesn't allow you. So,
but,
at least I don't think that the label would be after radio.
If Brian came to me, if he was here right now, I would be upset if you went with him and said, no, I'm
still deciding who I want to treat me.
So he's saying have 4 cycles and radiation therapy, it's okay, it doesn't matter that much. I'm saying, you definitely need the 9 cycles, and going off-piste and not getting the full treatment, that sounds like really bad. And by the way, you get one good go at bladder cancer.
But so Tom, only 50% patients got all 9 cycles.
I understand.
So Shilpa, what would you do in this circumstance? How are you going to handle patients who get neoadjuvant EVP, whatever CT, urinary tumor DNA?
I think we'll have a frank discussion with the informed patients.
And they refuse cystectomy.
Yeah, we won't force them for cystectomy because, Tom, I think your philosophy is also that most people will be able to preserve their bladders in future, right? So I think we have to use that data along with the tools like UTDNA, ctDNA, MRI, imaging, and there's now endpoints published in JCO for how to accurately measure clinical complete response and monitor patient closely.
Would you give radiation to the bladder?
after clinical complete response.
Sure.
So I think like right now, radiation is still, maybe radiation than doing nothing. Yes, I would do, because
give
just
radiation.
surveillance is not a
Jim,
good
could
option.
you bring some logic into this conversation, please?
I feel obliged to have to defend the urology community. Brian, you've got a great case. He won't accept cystectomy, but that's not the reality. Most people are shades of grey, aren't they? And your reluctance to undergo a treatment depends upon what else you're offering them on that way. And I guess even in complete response, so in the population we understand, pathological complete response, they still have a 10% recurrence and metastatic rate down the line. And so it's 90% survival, but it's not 100%. And in this case where you haven't done that treatment, albeit for the best intentions, when this comes back metastatic, what are you going to give that man or that patient? How are you going to feel? Because you've got Tom here saying you have to have the trial treatment all the way through, and then the natural temptation has not been to do that. But just as eggs are eggs, eventually it will fail in some patients, and then you'll be stuck with a very difficult situation.
Yeah, agreed. I think patients will be trading off. Am I going to take my chances that I'm not going to have a bad outcome? What am I going to do then? How's it going to turn out? I don't know. But I think, you tell me I don't have cystectomy discussions with patients. I think they're more worried about what's happening right now. Do I need this big operation right now? I don't think, that patients are thinking, well, if I don't have it and I fail, and I'm not saying they shouldn't, but I don't think they think that way. So I think there's going to be a lot of these conversations that are happening. Like you said, the urologist you're in, I think there's going to be a lot of these conversations happening.
I don't think the difficult conversations at that time, the difficult conversations in 18 months' time when they come back to you, when they have failed and you've missed a window, and then it's difficult. We're going to go that way. We need the evidence to prove it, because we need to know that extent and the difference in the change in management. But it is going to be a difficult time for the next few years if we rush at stopping after EVP complete response.
Carla from Toronto.
Yeah, so, fascinating show, fascinating discussion.
Carla, thanks for coming.
Thank you. So I think we do face this issue, and we do a lot of bladder sparing at our center. And I think I'm not currently comfortable with the data of doing nothing to the bladder. The retained data makes me very, very nervous. So in this situation, I would offer TMT, and I would offer the additional cycles. I agree with your point completely that the systemic therapy that we've done, that you did on the trial, has a benefit. And I think patients need to get that. I think we need to work to try to give them that agnostic, that choice. And those are the trials we need. But right now, if I have a patient who says, I will not have a cystectomy, I'm not comfortable doing nothing to that bladder.
Is that the last word on bladder cancer?
I agree with you.
Is it time for my question?
Yeah, I think we're going to move to kidney cancer.
Fabulous. I have prepared it here,
Tom.
Brian. So, Brian, I am a 53-year-old man. I have just had
You had to write that down?
surgery for an intermediate risk cancer.
Okay. You had a nephrectomy.
Yeah.
Yep.
And I've got clear cell renal cancer. It's pure clear cell, straight through. And the surgery's been successful. I'm up and about. And I've come to you and I said, I just saw a presentation suggesting that belzutifan with pembrolizumab is my best option. I'm up for it. And let's assume there's reimbursement and all the bits and pieces going.
Yeah. Tell me the pathology a little bit more.
It's grade 3.
Or just tell me the risk of recurrence if you want.
It's grade 3. Okay, I'll go for, it's a 40% risk of recurrence. 40. Yeah. Quite high risk. On placebo, on no treatment. The placebo, on the placebo.
Yeah, by nomograms, it's 40% based on grade and whatever. Okay. And I'm the doc in this situation giving you advice?
Well, that's kind of what you do for a living, isn't it?
Yeah. Listen, I think that the conversations I was having before ASCO GU were like this. I'd start out and talk about, here's how we estimate risk of recurrence. And I often go through with patients, when they come from surgeons, they're often not really sure why they're in my office sometimes. And I say, listen, many surgeries are successful, but some aren't. And here are the features we use to estimate risk of recurrence, grade and stage and whatnot. I talk about like the Fox-Chase nomogram, which we use. I also say that these tools to estimate risk are really poor. I think they're really poor tools. They're very crude. They're 20 to 25 years old. We do not have biologic tools.
Let's call it a high-grade tumor. Let's be clear, it is a high-grade tumor, but it doesn't have sarcomatoid features.
Yep.
Okay.
40% is sort of, on the cutoff for me. I think if somebody's below that, I tend to lean away from adjuvant therapy, right? And it's a benefit-risk discussion, right? And so it's, it's not right or wrong.
Okay. So I can see you breathing, Axel.
Breathing in your neck.
So, 40% in a young man, is that pembrolizumab currently? Let's just talk about pembrolizumab. You're giving pembrolizumab to those patients, surely?
At 40%, it'd be a discussion. I'm not necessarily pushing that patient.
Because those percentage benefits of OS for a 40-year-old individual who's up for it, they are going to be more. They're going to be 7% more patients.
No, listen, if they're up for it, I'm going to give it.
7% more alive at 5 years.
5%. Yep.
Yeah. Well, in a slightly higher risk population compared to the whole thing.
Now we're talking about subsets. Okay.
Okay. No. Okay. I'll be fine. I'll go with 5. Yeah. I'll go with 5. But if 40% is higher than the control, okay, I'll go with 5. That's an overall survival benefit for a year of immune checkpoint inhibition. Is that not clear to you?
No, it's clear to me. I understand the data. I think really the philosophical discussion is because there's an OS benefit, does that mean you have to give it to every single patient who's eligible?
You don't have to. There'll be people who don't want it, but
but everybody who's eligible and wants it.
Jim's point, which is right, is in the end, as a doctor, you have a lot of influence. I'm not brought into this shared decision-making discussion.
But Tom, why would you have a...
I thought I had to finish my sentence. Okay, I want to come back to that. I want to come back to it, because I know that will go down really badly.
So, if I understand you correctly, you would like
no
to
one understands me correctly. That's half the problem, Axel.
Pembrolizumab based on the data that we presented. But why would you want to have an adjuvant therapy that currently has no OS benefit?
Well, Pembro does.
Pembro does,
yes,
but not pembrolizumab.
Okay. So the answer to that question is there. And all we need to do is go back in time. And we go back to Tony's original presentation, 564 ASCO GU 3 or 4 years ago. And he showed very, very similar data. He showed a significant benefit in disease-free survival with pembrolizumab across broad subgroups of patients. He showed the curves go apart, they stay apart. He showed, as we did here, when we subsequently showed a metastasis-free survival advantage, a PFS2 signal, and then we had immature OS, the original hazard ratio with the original, and then guess what? That OS hazard ratio, as it became more mature, was statistically significant.
I would agree, but
and then,
at this moment we don't know that.
Yeah, but you don't get 2 goes at adjuvant therapy, actually. You can't go back to that patient and say, don't worry, what we'll do is we'll come back in 2 years' time and have the conversation. And so that's fine. You come back 2 years later and said, you know what is now mature, so we're going to give you the adjuvant therapy now. Because that's too late.
Yeah, but you can reasonably make a decision not to give it until there's mature OS.
Yeah, but you'd be wrong to say that there's not going to be OS at this point, and you'd be wrong to say that the indicators at the moment...
Well, we don't know.
The indicators at the moment are running parallel to what we did previously with 564.
Yeah, I'm not quite sure. I don't think that's the difference is slight.
What's the difference?
So first of all, I think at the moment the curves go up at 2 years. That was the same as in Keynote. I would agree, but I think the signal we saw there was a bit more pronounced. And currently, if you look at it,
a bit more pronounced with
0.78. There's a numerical difference of 11 people who died. So 38, 49,
but Axel,
could be anyway.
Axel,
you're just adding
I know you're a scholar of history. We chat about history all the time. And you love the past, but yet you're not prepared here to look at the past and learn to the future.
But Tom, just because one trial followed a pattern...
Why is that, Axel?
Tom,
why is that?
Just because one trial followed a pattern doesn't mean the next trial is going to follow the same pattern. That makes no sense.
Exactly.
Right?
But it
564.
But it could. Like if the hazard ratio was 1.1, but it could.
Or it could not, right? We don't know.
But there is. What about PFS2 and these other bits and pieces?
Oh God! Don't get me started on PFS2. So
look, I don't love PFS2 either.
But yet you stood up and presented PFS2.
No, that's because that is because PFS2 is a fair indicator of what might happen in the future.
You could tell when Tom's worked up, the pitch of his voice.
I didn't say PFS2 was important. I just said MFS and PFS2 give us some. The breast cancer doctors do this all the time. They give you some because those OS curves at the moment are 96%. You can't. I agree. You can't tell that much from that. So we have to look at other indicators when we're making informed decisions, and things like PFS2 and MFS. The discussant is here. Eduardo, come up and give me a hand, please.
Give me a rescue here.
Yeah, thanks, Tom. Thanks for having me.
Eduardo, introduce yourself. I loved your discussion, by the way.
I'm Edward. I'm working in Belgium as a urologist, so I'm not a medical oncologist. I discussed the LightSpark 22 trial, but I think I have to side a little bit with you here because I know I am a surgeon, not a medical oncologist, so I think we can heal people with surgery alone. But on the other hand, you have these patients that just ask us, like, I want to do everything, even though there might not be OS benefit. This is something we have discussed. We all want the data. But if these indicators are here, there are a lot of patients that say, like, I want to take the risk. I want to do everything. I want to have the added toxicity, I guess, if it's good to decrease the recurrences. So I would not offer it to everybody, but still there will be some patients that absolutely want to do everything. No?
And that's totally fine, right? If a patient comes in and says, I want to do everything, I understand the risk, including the risk of death, right? In patients who may not have had recurrence, small but real.
But Tom
if they want to, that's okay.
Tom said he was up for it.
0.3%.
So that's not zero, right?
No, but your chance of dying of kidney cancer is 40%.
Right, but I'm saying those 6 patients who died in 022 could have never had recurrence, correct?
Absolutely.
I'm not saying. All I'm saying is, if you were going to have an informed discussion with a patient,
I agree,
part of the
it's part of
package.
the package.
You might die.
But the treatment-related death is not like it's, the most dangerous thing about swimming in the sea in Sydney is not getting eaten by a shark, it's crossing the road to get there. But people are more worried about being eaten by a shark. It's the way you present these things. If you say, oh, yeah, there's a big chance of death and blah, 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 and we had 5 patients die. So it has to be
I
a
didn't say
balanced
a big
discussion.
chance of death. Those weren't the words I used.
Okay,
yeah.
fine.
But there were also 3 deaths in the pembro monotherapy arm.
For sure.
And there were 0 deaths in the Keynote 564 trial. So obviously we don't want any people to die from treatment-related toxicity, but it is extremely low. I think because it's a lot more patients in this trial. It's 1,800 patients.
I think
it might be very frail people, relatively. I don't know.
I think, again, it's, we're talking about benefit and risk here, right? The benefits are DFS now,
Absolutely.
May or may not be OS. You might think there is based on other indicators. I might be more reserved about it. Doesn't really matter. I mean, it is what it is, but the data is the data now. And also the risks are there now, right? The added toxicity of Belzu, right? And so you can have that discussion with the patient. Although in your scenario, I have a 60% chance of already being cured by my surgeon.
I'd like to ask the pair of you, I want to Axel as well. Is there any indication for single agent pembrolizumab, or does everyone get the combination of pembrolizumab and belzutifan? Those that wanted it, if you've made the decision around risk, and you've made the decision, the shared decision, which I was a bit rude about a few minutes ago.
A little bit.
I apologise. That you're going to do something. Is it pembro or is it the combination?
I think it could be pembro monotherapy. I don't know. I've not had that discussion with patients yet, but I think you could say, Doc, I want to do everything. Let me talk. I want to do everything, but I want to do everything that extends my survival. Okay, well then it's pembro mono. Right? What Eduardo says, Doc, I want to be as aggressive as possible. Give me everything. I understand the risks. I'll light myself on fire, which some patients say. Then it could be the combo. But I don't think you can say it's all or nothing. I don't think that's right.
You don't. All or nothing.
I think for now, all.
All. Axel, all or nothing.
Well, I would just say, pembro is the current standard of care, and the DFS is positive, but we don't have the overall survival benefit. And therefore, I would say, I would still advise patients to have pembrolizumab for the time being. And we will have to discuss this in the guidelines. And I can imagine, because we have precedent, so I can only speak on personal opinions because we will have to discuss it in the guidelines. But we will probably come up with a weak recommendation because the OS signal isn't there yet. Yeah, or the signal is there, but it's not statistically significant. So that would mean for the community, if a patient wants it, you can give it. But I think the current standard with a strong recommendation is still pembro mono. So that recommendations aren't that helpful for patients because weak and strong, both are recommendations. You sit there as a patient, you say, well, they're both recommended. What's the conversation that you have with the patient? So they come in, this 53-year-old person wandering around, once they're up for therapy, they understand the risks associated with it, including death. In adjuvant therapy, it has always been about overall survival as well. Right. Since years we are waiting for these signals, and that was also why Keynote was such a bummer when it came in, because it had for the first time overall survival difference. Because otherwise, we are not looking at symptomatic progression. This is radiological progression, and just because people have a slight delay in progression or not, it makes a difference in the emotional status. But it may not. It may be just radiological window dressing. What's the conversation? And you add a lot of toxicity to them as well. So let's just talk about the toxicity, if we may, because we haven't really focused on that. The toxicity with immune checkpoint inhibition is relatively low, but potentially devastating. The adverse events
with belzutifan are potentially higher in that it's like like when you see the forest plot, it's more like chemotherapy drugs. It's fatigue, it's the things we measure, and we don't measure those tornado plots don't measure immune tox. They don't remember the 1% cardiac tox. They don't so we've always got away with immune toxicity and was always brilliantly tolerated. Quality of life no difference. We asked all the wrong questions, and the toxicity looks absolutely fine, but it doesn't talk about those 10% of patients that got life-changing toxicity. With this drug, it's there for all to see, but that toxicity is probably easier to manage. It's fatigue.
I don't know that it's easier to manage.
It's fatigue. It's anemia.
I'll agree with you. It's less devastating in that small subset, but I'm not sure it's easier.
But you stop it, it goes away.
But it adds to the toxicity.
Yeah, but you can just stop it. Like you're saying to me, look, I'm pushing you. You don't want to do it. I'm pushing you.
Why starting in the first place?
I'm pushing you. Look, bear with me. Both of you are saying you're not sure you're giving it to everyone, although it has PFS. And so I'm saying to you, I'm a patient. Why don't we just start it and see what happens? What's the downside?
You could do that.
Okay.
Yeah.
Oh. Okay. Axel.
But you don't have to do it. I think that's the difference, right? I don't think it's mandatory. I think, again, if a patient said, "Doc, I understand the risks. I understand the benefits," then sure. I mean, that's what's called shared decision making. Tom, we'll talk about it after the show.
Yes, but we do need a lecture on that.
But maybe Silva has something more.
So I have a question. I was curious in the LightSpark trial, the M1 NEDs. Why was the time period 12 months? If they have such indolent metastatic disease, and if it's resected a year ago,
it was 24 months in 022. It was 12
So why? In a patient who had 24 months ago, why would we give something, a doublet?
I mean,
what is the rationale?
You think it's too long?
Yeah,
yes.
I mean, so I have two different ways of looking at this. So if you look at, so I think you also published on this, the Leuven-Udine score on, so having a metastasis, a recurrence in the first year is actually a prognostically unfavorable factor. And very often, before we had Keynote, I think in our surgical MDTs, if you do nephrectomy and the lymph node pops up 3 months after surgery, our normal reaction would be to just observe it for another 3 months to see whether hell breaks loose. And if this doesn't happen, then you could probably go for local treatment. So I think when we did the same in iMotion 010, we were looking at metastasis longer than a year. Remember that. And that led to different results, but maybe atezolizumab was also a different drug. So I don't know whether these early metastatic patients are actually the ones that should receive adjuvant therapy because they are probably already the rapid progressors.
They should
receive
a double.
It drives the event rate in a trial. And that
I think it's a really complicated area. And I think the resected M1 NEDs are an extremely heterogeneous group. Right. And time to recurrence is one factor, but it's not the only factor, right? Site, resectability, number of mets, organ. I mean, there's all these things. And so it's a widely heterogeneous group. So I think it's hard to make broad statements. I don't give adjuvant pembro to resected M1 NED because I think it's under treatment. Yeah. Right. Those patients have such a high risk of recurrence.
Can we mention 8Y8? We'll have to.
They have such a high risk of recurrence. If it was me, I'd rather wait. And if I recur, give me doublet.
I think the M1 NED population is a distraction from the main part of the trial, in my opinion.
I agree. It was 5% in the trial, 9% in 022.
Small numbers. I don't think it's particularly helpful. And I'm keen it doesn't become, I don't think it should be a major distraction when we discuss with patients. And I'm not pursuing that. And if people do want to do that, that's up to them. But that's not the main part of what we're trying to do. Brian, by the way, if someone wants us to talk about something else, please come to the microphone.
Can I ask one more question,
yes, of
Brian?
Course, sure.
Intensifying the adjuvant treatment with belzutifan. And what happens in the frontline upcoming triplet trials with belzutifan? Like, is the approach to do the kitchen sink in the adjuvant setting and then think later about what to do in the frontline? I would love to hear where the field is headed.
It's a good question. I mean, again, I'm not quite to the kitchen sink in the adjuvant setting yet, but I generally make treatment decisions with the patient in front of me. So I wouldn't necessarily not give the treatment because I'm worried about frontline. I might not give it for other reasons, but I wouldn't for that reason. What Chilp was referring to is 012, which is triplet study with Belzu. And, If that's positive, will there be retreatment of patients who got adjuvant pembro belzu? I think yes. I think it's very different than immune therapy. I'm not a retreater with immune therapy because there's not a bit of evidence that it's helpful. But I think targeted therapy is different. And we'll get into discussions about, is it 6 months or 12 months and all that? I think those are more rational discussions with the targeted therapy. With immune therapy, I don't think so.
Brian, so this individual has agreed to start the combination.
Yes, and handsome 53-year-old individual.
And he's becoming anemic and he's 9 months in.
Okay.
Are you giving him erythropoietin or are you stopping therapy? Or are you giving a blood transfusion? The hemoglobin started at 12.5, is now is now 9 point or 8.6. I don't want a blood. I'd rather get through. I don't want a blood transfusion.
I haven't given a blood transfusion for a HIF inhibitor anemia in a really long time, and I've given a lot of them.
Yep.
You know, I think I use a lot of EPO. ESAs, erythroid stimulating agents early and often. So in this patient, I might have a little bit of a discussion and say, listen, we don't know that 12 months is magical. It happens to be 1 calendar year, which is why I was using the trial. Totally reasonable. But ESAs, to me, they're just so easy. They're not hard to do. I've not.
Do you worry it might make the cancer grow faster?
No, not at all.
Why are you not worried? But a chapter of my PhD was, my MD was on that. Why? It was you've obviously not read it.
I mean, I don't think there's any evidence of it. I think that the data is old, and that's when we were pushing patients to hemoglobins of 14, 15, right? I don't think there's any evidence of it in RCC. And I'm not pushing, basically if they're below 10, 9, I think it was 8.5 in your example, I'd start it. Once they get above 10, I'm holding it. And for this patient, they're going to end up with 2 or 3 EPO shots, right? But if they also said, hey, doc, I'm not really into these shots, I want to stop at 9 months, I'd probably say fine. So I don't think I'd push them either way, but I'd be happy to use ESAs in that setting. Obviously, I haven't come across it, but.
And what about how in the adjuvant studies, we've been keener, and we can see this from the data, to not push therapy. So the proportion of patients who discontinue therapy is higher in the adjuvant setting than it is in the metastatic setting. How much toxicity are you prepared to go through with belzutifan before you stop it?
I mean, not a ton. I think I have a pretty low threshold to stop adjuvant therapy for tox because obviously I don't know if that patient's going to recur. And I also don't know if that individual patient's benefiting, right? I only know if they didn't benefit if they progress through it. So historically with pembro mono, I'm talking about, I get some creatinine bumps after 2 or 3 doses and I'm like, nephritis, I get nervous and I stop. So I have a pretty low threshold. If you're asking about the belzu component, I guess I'd be maybe more likely to push that, but honestly, I haven't thought through it.
If we can switch gears just really briefly, and I know we haven't got much time, and please do, if you have one burning question, we're up for it. But we did agree, or we didn't agree, but I thought we should talk about the LightSpark data with a combination of lenvatinib and belzutifan versus cabo. That's a study which is in pre-treated patients that have had prior immune therapy. They're getting the standard of care, which is cabozantinib, which we always felt has been super hard to beat. Yeah. And then you've got lenvatinib and belzutifan. Of the 2 trials, of the adjuvant trial and the metastatic study, which do you think are more impactful? And how would you score both trials out of 10? In terms of your enthusiasm?
I think 011 in the refractory is certainly more immediately impactful if you're talking about how many people I think will adopt it, on day one, so to speak, right?
Who are you going to give it to?
Who am I going to give it to? Well, I give a lot of len pembro on the front line. I wouldn't change that. So for me personally, it wouldn't be many, but But
you just said it's going to be really impactful, but you're not giving it to anyone.
Well, are you talking about in my practice or broadly? Broadly, I think it'll be more impactful. For me personally, it won't because I give len pembro up front.
Me too.
Right.
So it's not.
But there are plenty of people who don't give len pembro up front. Right?
But you wouldn't switch away from len pembro to give this?
No, I wouldn't change my frontline therapy.
But you did axi pembro originally. Why not go back to what we started with? You remember that hazard ratio 0.53 OS? You remember that day?
I do remember.
Why not axi pembro first, then len?
I mean, you could. I'm not saying that's wrong, but I personally won't change my front line just so that I can give this second line. Where again, we have PFS without OS yet.
Ipi-Nivo, post-Ipi-Nivo, would you treat?
Sure. Great regimen. But again, these are non-curative regimens, right? So now we're having a very different discussion than the adjuvant setting.
So why is
these are all non-curative?
So you've just said it's more impactful than the adjuvant study, which I disagree with, by the way. But you're saying, number one, it's not curative, and number two is you're not going to use it. It doesn't sound very impactful at all to me.
My definition of impactful is that I think on day one, if both these regimens were approved tomorrow, I think more people will use len-bel in the refractory setting. a higher percentage of practitioners, forgetting about the number of eligible patients. There's probably more adjuvant patients, right? So that's my definition of impactful.
To my impact is slightly different. I see earlier disease. I think belzutifan is probably a better drug giving a bit earlier.
Mm-hmm. I agree.
And under those circumstances, and I think having positive trials in the adjuvant setting for DFS means more than in the metastatic setting, which we've had quite a few of before, including, for example, your axitinib-sorafenib trial. I didn't want to bring that up, but I feel I needed to. So under those circumstances, I feel the adjuvant space is much more impactful than the second-line metastatic, which is palliative, and you can sequence the drugs there anyway.
Yeah, I don't disagree. I think it's more potentially impactful. Again, it depends how you define it. I was sort of using impactful more in like, do I think people are going to use it on day one?
Okay.
Like, is it going to impact practice? Now, I agree. The adjuvant's obviously a bigger space, more long-term outcomes. So I don't disagree with you.
Axel, could I ask you a last question? There's going to be a guidelines meeting for the EAU guidelines. We're going to discuss these. Just discuss how you think the European... You've got no idea. We've not met yet. We don't know what it's going to show. You chair. I don't think you even voted. I can't remember. So just tell me how you think the decision-making about these two pivotal trials, the adjuvant trial and the immune refractory second-line or third-line trial, what conversation is going to happen? Neither have OS, both have DFS, both have positive signals, both have a toxicity signal. What are the two conversations that are going to take place? And what do you think? Where do you think this ends?
You mean within the guideline?
How do you feel that? Yeah, I mean, obviously we haven't done it yet, so it's easy. But you can predict what you feel might happen.
So what we always did is when we look at the trials, we always look at the primary endpoints. We also look at we don't call it grade anymore. We look at the forest plot exploratory analyses and then look at the harms benefit ratio and then come up with a kind of recommendation. So without being too prophetic, I could imagine that we will very likely, so we will discuss it in, I think, next week. And then if we reach consensus, then I could imagine that we take the precedent as we did with Keynote before we had overall survival, and would say exactly what your argument was. Maybe in 2 years' time it becomes positive, so we don't want to create an opportunity that patients don't get it. But for LightSpark 11, I think...
this is the second-line, third-line metastatic study.
Yeah, exactly.
So that's the adjuvant trial. You think it's going to go in the same direction, the original direction of 564?
Very likely
Why
a weak
wouldn't
recommendation.
And you'll still continue the strong recommendation for Pembro.
Personal opinion for those ones who listen, it's not guidline recommendation yet, but it's about...
No, it might not be, because people might disagree with you, but this is your take on it. Yeah, and just tell me what you think what your take on the frontline metastatic, on the second-line metastatic, third-line metastatic, lenvatinib, belzutifan.
So obviously I'm not a medical oncologist. I think lenvatinib and belzutifan, they have their toxicities and all that.
But you know how the committee, you know how we discuss it.
So, obviously. So I think cabozantinib is a powerful drug. The fact that it has been beaten in DFS, and DFS is important in those later lines.
Can I push you on that, Axel? We're going to finish soon, I'm sorry, but I'm going to push you on that.
Yeah. So I think it will be recommended as well.
Well. We have not been keen on DFS in advanced disease. We've always gone with OS recently, haven't we? With the exception was belzutifan, heavily pretreated. With the original targeted therapy trials, the sunitinib trials and the axitinib trials, the targeted but we never gave avelumab.
But wasn't LightSpark 005 was also PFS only, not OS?
Correct.
And that was compared to the weakest kid on the block, everolimus, after a couple of lines. So here we have a trial that is a real classical sequencing trial. So I think 67% of the patients were being included after having received one line of treatment. So I think this is the classic situation. And then you demonstrate that you have a DFS benefit. And I think, as someone put it, if you have a good drug in this situation, better go for DFS. And I'm confident that with time an OS signal might occur, but it's also very difficult in these lines because a lot of people get other drugs afterwards. So it might be diluted. Well, I think the DFS benefit is quite compelling.
Axel, are we good? Can we call it?
Yeah.
All right.
Axel, thank you. Thanks. Jim, Mikhail, Eduardo, Shilpa, Carla. Thank you very much indeed. Thanks for joining us.
Thanks,
I hope you enjoyed the rest of the meeting. Thank you.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favourite podcast app. Until next time, keep learning and stay inspired.